Okay, so can we see my slides, please? Okay, so thank you for the presentation. So I'm an associate professor at the Karolinska Institute, but I have a conflict of interest, as Jean-Michel mentioned. So besides lectures for Abbott and AbbVie and advisory board membership with Baxter Global, I am also currently working as a chief medical officer for Solara Medical. And I'm actively working with research and regulatory issues to get isoflurane labeled for ICU stations. That's an important conflict of interest that everyone should know. So now we can move over to slide 3. So sedation in general has been my topic of interest for the 20 years I've worked as a clinician. And going back to the guidelines from the Society of Critical Care Medicine from 2002, I think they very well describe why we actually use sedation for patients. Of course, non-pharmacological management is to be preferred, but sometimes we need drugs. And then we give them for 2 reasons. One is for the comfort of the patient, and the second is for the safety of the patient. And when it comes to comfort, the immediate and more long-term aspects, with immediate being the pharmacological treatment of anxiety and fear, and long-term post-traumatic stress is one of the complications of critical care, and this can be elicited by the relatively traumatic experience it is to be intubated and awake. There's a paucity of data on different drugs and strategies when it comes to what is best for the comfort long-term for the patient. When it comes to safety, this is about us being able to give patients optimal ventilator treatment and other treatment in the different phases of critical care. If we move over to slide 4, as highlighted by the good guidelines from 2018 from the PADIS guidelines, in the critically ill patient, there are potential problems when sedative drugs are given. And patients that have multiple organ failure can have difficulties in eliminating these drugs and their metabolites. We move over to slide 5. There is a list of documented problems with high and liberal doses of intravenous sedatives. Delirium with the benzodiazepines. We have long, unpredictable wake-up times, which I think everyone recognizes from having used benzodiazepines for years. Sometimes the patient will wake up in an hour. Sometimes it will take a week. And this is particularly problematic in patients with multiple organ failure. Propofol may be relatively short-acting, but with high doses and long duration of treatment, there is a risk of propofol infusion syndrome. And in the SPICE-3 study, bradycardia and asystole were more common with dexmedetomidine than with usual care. And this is also something that warrants caution. And generally, for intravenous sedation that's not well controlled, there's a risk of prolonging ventilator times, ICU stay, and hospital stay. Let's move to the next slide, please. And the different ways of managing this, as was mentioned by the previous speaker, daily wake-up is one strategy. Protecting lighter levels of sedation is another strategy. These two strategies have similar efficacy when it comes to reducing the iatrogenic problems of oversedation, namely ICU's length of stay and ventilator times. And even in the study from Strum and co-workers from 2012, there was even a suggestion not to use any sedation. Now that study, as mentioned, has some caveats, among others. If one goes into the analysis, you will see that many patients received propofol in the no sedation group, and also that patients that died within 48 hours or were still on the ventilator for 30 days were removed from the analysis. So I think one needs to interpret that with caution. What is clear, I think, both from clinical practice and from the various attempts to manage patients with different strategies and with different drugs, is that patients are different, and also the course of illness changes over time. So I think one of the things I think we would all agree on is that one needs to consider the patient and the situation when one decides what type of sedation or what kind of interventions should be used. Let's go to the next slide, please. And so the SPICE-3 study described like an ICU sedation real-life scenario. The 4,000 patients that were included very early on in their course of mechanical ventilation, within 12 hours from intubation. And at this time, the researchers decided to target RASS -2 to +1. And as mentioned, there was no difference in the all-cause 90-day mortality, which is the primary endpoint. There were very few of the endpoints actually that where any significant difference was found. But if we go to the next slide, we will see the next slide. Thank you. So here we can see the proportion of patients with a clinical indication for deep sedation. And as you can see, the first day, 60% of the patients were deemed to need deep sedation being RASS -3 or deeper. Second day, 50%. And as time goes, there was a reduction in the proportion of patients that was considered to need deep sedation. And this also, I think, describes something I think many clinicians recognize, that when you intubate your patient, maybe the first day, light sedation may not be what you'll be targeting. But as time goes, you can feel more and more comfortable with moving the patient towards light sedation and aiming at extubation mobilization. And so if we go to the next slide, you could say there is a dilemma then in the early phase of mechanical ventilation between guidelines, recommendations to target light sedation, and a real-life scenario where patients may be undergoing ARDS treatment with prone positioning, neuromuscular blockade. They may be receiving various interventions and diagnostics where the physician feels that for safety reasons it's better to sedate the patient deeply. How can we manage this without causing those problems of long wake-up times, long time in the ICU? Perhaps inhaled anesthetic sedation could be helpful there as a forgiving option to manage these patients when they need deeper than light sedation. Can we move to the next slide? Thank you. Inhaled anesthetics are used in the operating room, and those who have used them know that they have rapid onset but also rapid offset, and the accumulation and metabolism of these drugs is negligible, and so that makes them a potential option for patients that have organ dysfunctions. Currently, there is a simplified delivery system available, among others. The Anaconda is one way of giving volatile anesthetics. That's manufactured by the company I work for, Sedana Medical. There are other ways of giving volatiles as well. I'd like to rather focus on the drugs themselves. The pharmacodynamics and pharmacokinetics of these drugs actually do make them suitable for a patient that has poor renal function or poor liver function. And the rapid recovery that can be seen after deep sedation is well demonstrated in the two box plots you see here. The left one is from a study from Karolinska where patients were given either isoflurane or midazolam, and they were extubated very quickly after isoflurane, even though they were oversedated most of the time. And in the midazolam group, it took significantly longer, and the extubation time was not so predictable. The same goes for the study by Messner and co-workers, where sevoflurane sedation was associated with very rapid wake-up. In other words, even if you sedate patients with these drugs with rather deep sedation, the moment you decide you want to have light sedation or wake them up, you can do that within minutes. And that could be a potential advantage to the intravenous drugs. Let's move to the next slide, please. Besides these rapid recovery features of inhaled sedation, there may be other potential benefits. Anti-inflammatory effects have been demonstrated for both isoflurane and sevoflurane, and in animal studies of ARDS, the development of pulmonary extravascular lung water, impairment of gas exchange, and poor oxygenation has been ameliorated by inhaled anesthetics. This was also demonstrated in humans in moderate and severe ARDS in a study by Dr. Jabadon and Jean-Michel Constantin from Clermont-Ferrand. It was demonstrated that 48 hours of sevoflurane compared to midazolam in patients that were receiving neuromuscular blockers led to an improvement in oxygenation after 48 hours, which was the primary endpoint, but also in reduction in inflammatory cytokines and in markers of pulmonary epithelial injury, SRAGE. And I would say this is particularly interesting in these days of the coronavirus and ARDS, where the cytokine storm is what leads patients into the ICU, causing ARDS and also driving mortality. This could be a potential additional benefit. Let's move to the next slide, please. So besides the PADIS guidelines, the ABCDEF ICU liberation bundles are something that's on everyone's lips today, and it's an integrated so to say, management, but also therapeutic approach in order to get the patient out of the ICU in a good shape. And if we go through the A, B, C, D, E, F, I would like to state that Spontaneous breathing is facilitated by inhaled anesthetics. This is demonstrated in several studies that spontaneous breathing is promoted with inhaled sedation versus IV. Awakening is very rapid. The choice of analgesia and sedation, the C, this I would say refers to choosing the right drug for the right patient at the right time. And I would state that if you need deep sedation, maybe this is the best option. This may not be the right option for light sedation. And I would say that had I done the SPICE-3 trial, I would not have gone for early mechanical ventilation. I would have gone for the later phase when patients are able to be more awake, when the ICU situation is not like in the operating room, which is the first 24 hours, but rather a situation where you are trying to mobilize the patient and get them out of bed. But for the early phase and deeper sedation, maybe inhaled anesthetics would be the good option. And early mobility, this refers to the fact that patients actually can wake up and cooperate at a very early stage when they receive inhaled anesthetics for sedation. And this has been demonstrated in a few studies. So that's, if we go to the last slide, the studies today are all very small and they are all very promising, I would say, most of the studies, but there's no large randomized controlled trial that has been published yet. There are some large retrospective studies that are also promising. We have a trial that is being run actually by Salam Medical, IsoConDa study, where we'll have the first results will be presented this spring. And there are also other RCTs that are underway, among others an RCT of sevoflurane in ARDS led by Dr. Mathieu Jobadon from Clermont-Ferrand that will be starting this spring. And this is a study to evaluate potential benefits in ARDS, and also a study that's being led also in France by Professor Aaron Lair and Dr. Pierre Bailly in breast that will evaluate potential effects on delirium. So I hope that there will be more information on potential benefits in larger randomized controlled trials. But at least I would say for today, inhaled sedation in the situation where you need deeper sedation is a promising alternative. Thank you.
Thank you so much, Peter, for this nice overview and for your last slide. Because I think some of us think that volatile are useful in ICU. Some others say that we need much more data before using volatile in ICU. And maybe, according to what we say, during the next few months, we will have some new data from our friend from Germany. So it could help us that using volatile in ICU. Some of you have one question for Peter?
Hi, Peter. It's Jean-François.
Hi.
Yeah. I have a question. We all know that volatile agents may offer some advantages over IV sedatives. But one issue is the risk for the pollution in the room of the ICU. So how to deal with the use of scavengers system, and how to fix this problem?
Yeah. So this is a concern in most ICUs where this therapy is initiated. There are two ways of scavenging, actually. One is a passive system and the other is active. An active system means that you actually use your own hospital exhaust system and you have a reservoir that is connected to the exhaust side of the ventilator. This is a solution that's usually solved locally with medical technical staff in the hospital. The other option is to actually have a disposable scavenging system that's a passive system where air from the ventilator is led through this a cylinder that adsorbs, it's an active carbon cylinder that adsorbs volatile anesthetic. And with the use of these, it's been demonstrated in several studies that the levels of volatile in the room are barely measurable and far below all recommended exposure limits, and so those are the two ways that one can manage scavenging. And I should also say that the system I'm describing, this AnaConDa system, it recycles most of the volatile. So what the patient's receiving, about 10% of that goes through the reflector. So what's leaving the ventilator is 1/10 of what the patient is receiving. So we're talking about 0.05%. So in itself, it's a very low concentration. We did a study at Karolinska where we actually used scavenging, and we were measuring continuously. We also measured the exposure levels on the nurse's lapel, and levels were so low, and we had the levels online. So we decided to do 5 patients without any scavenging, and we still didn't have any detectable levels due to the room turnover. I would still not recommend not using any scavenging. I would still say one should use scavenging, but I would say all data so far are reassuring, and I think that this is something that we'll need to have a few more publications for, because this is of course a concern for staff. But levels in the post anesthesia room are higher than in the ICU when you use this technique.
Thank you so much, Peter. Just to move on because time is going.